All right, welcome everyone. You are joining the National Center for Medical Legal Partnership, as well as our very special guest today on March 20th at 2 p.m. Eastern Time here on Zoom for a special training webinar where we're going to address how to improve maternal health access and outcomes through medical legal partnership, or as we like to abbreviate, MLP. Let's go to the next slide. We're going to be pretty conversational today, but I just want to make sure you know who we all are and you have some visuals on the screen to aid in today's learning and participation experience. So I'm Bethany Hamilton. I'm director of the National Center for Medical Legal Partnership, and we're based at the Milken Institute School of Public Health here at George Washington University in DC. I will be today's moderator, posing questions to our subject matter experts who have joined us today to share their knowledge and experience in MLP for maternal health. Next slide. Brief housekeeping. As you know, we have joined on Zoom, and so everyone's automatically on mute, but we strongly encourage everyone to utilize the chat or the Q&A to engage. Ask your questions. You don't need to wait. We'll be monitoring the chat as well as the Q&A to ensure that we are able to address questions either as we talk or have the discussion today, or at the end where there's dedicated time to do so. If you need any assistance, send a chat directly to us as host and panelist. So in Zoom, in the chat, you can actually select to send your chat directly to host and panelist. That's where you'll send us a message if you need some technical assistance. If you need to activate captions on Zoom, you can select live transcript and then show subtitle to allow the captions to appear. If you need assistance with that, send us a direct chat. Finally, we know folks will ask, and the answer is yes. This webinar is being recorded, and both the recording as well as the slide deck, if you want to track along with the recording, will be posted on the NCMLP website. Our colleague Reha, our center associate, has posted the link to the website resources page in the chat. All right, next slide. These are today's learning objectives. We hope by the end of the webinar event, you will be able to leverage clinical and non-clinical measures to address social risk factors that impact maternal health, access, and outcomes. We also hope that you'll be able to plan or implement MLP strategies to create an integrated multi-sector response to perinatal health. And finally, we hope you'll actually be able to utilize the MLP approach or intervention to develop and pursue systemic change and improve population health. Let's go to the next slide. Okay, so here's the agenda, roughly estimating how much time we'll spend together going through different segments. I will introduce the speakers today. I will then play a very, very short video explaining the why we're here and helping people really ground themselves in some considerations, for maternal health, as well as addressing opioids and substance use disorder. And then we'll have a conversation with our subject matter experts, who are the MLP practitioners, about the what and the how that their organizations partner, what purpose they partner for, what are the components of their partnerships, what services they provide, and what they've seen in terms of outcomes thus far. And then hear an example of how some of those outcomes have played out for a patient who has gone through the legal journey with this MLP. And then we'll pause to have some Q&A with you all in the audience. So plug your questions in the chat, whether it's in advance or if you want to wait until that point, that's fine as well. And then we'll close out and ensure that you have some additional resources to support your work going forward. Next slide. So on this next slide, you can see that our very special guests today who are stepping away from their day-to-day work on this MLP and other interventions are first and foremost Executive Director of New Hampshire Legal Assistant, Sarah Matson-Dustin. Thank you for joining us, Sarah. We're also joined by the MLP staff attorney, also from New Hampshire Legal Assistant, Jonathan Teller-Ellsberg. Thank you for joining us, Jonathan. And we're joined from the healthcare partner, clinical director of the Dartmouth Health Moms in Recovery Program, Terry LaRocque. Terry, thank you so much for joining us today as well. Let's dive right into the first part here, which is a brief video. We're going to play this video. If for some reason the audio doesn't work, we'll also plug a link in the chat to this video. So please indulge us for just a couple of minutes as we view the March of Dimes Stories of Substance Use Stigma video. Thanks.
I started using drugs when I was 19. I was introduced to them by a boyfriend. From 19 on, I used pretty much anything I could get my hands on up until I was arrested. And when I was arrested, I discovered I was pregnant.
My path to addiction probably started a little later in my life. I went to college, I went to school, graduated top of my class, had a good career, and I didn't start using until I was 29.
So I was scared, I was worried there was... I started using drugs when I was 19. I was introduced to them by a boyfriend. From 19 on, I used pretty much anything I could get my hands on up until I was arrested. And when I was arrested, I discovered I was pregnant.
My path to addiction probably started a little later in my life. I went to college, I went to school, graduated top of my class, had a good career, and I didn't start using until I was 29.
So I was scared, I was worried there was going to be something wrong with my baby. I was wanting all the medical care I could get, and I just wasn't getting it.
And then I found out that I was pregnant. I knew that I had to do something, but I just had such trouble getting help.
We were waiting on the ambulance to get there, and his supervisor came over the phone and he was like, "Is that pregnant idiot still back there, or has the ambulance come and picked her up yet?" Whether you're clean or not, you're kind of always labeled a drug addict. It's really hard.
I didn't say anything to the doctors because I was afraid of the consequences. I thought they would take my baby. My family would find out. The stakes seemed so high. Without, I knew I had to do something before he was born. So I go in, I do the assessment. She didn't make eye contact or look at me the whole time.
I was judged more harshly. You can usually see it on their face by being called junkies and just addicts. It's just a dirty term.
Think of it person first and not I'm an addict, but a person with an addiction, just like a person with an affliction. And I think that would help with the stigma.
I mean, we're people just like everybody else. And I think labels like that, they really are dehumanizing. It makes you feel like less than people.
Addiction doesn't have any creed or any discrimination. It's a disease just like diabetes. It's not anything that you do purposefully.
One thing I think healthcare providers could do to help encourage people coming in to get help is just to remain professional. Treat us just like you would any other patient, especially if they're there to get help. Because being judgmental and stuff like that, we can see it. We're not blind. We can see whenever you're judging us for something like that. And it'll keep us from seeking help.
I would say the difference between the facilities versus here is vastly different. I didn't feel like I was in trouble or being criminalized. They asked me what I needed, what my goals were, what my son needed.
When I see him smiling, laughing, playing, it gives me hope for the future that I'm going to be able to hold on to this and to get clean. And I think I'm actually going to make it this time.
Great. Thanks, everyone, for indulging for a moment while we talk about how patients are encountering the healthcare system as they're in recovery. And on the screen, you'll now see some points about how we can counter that. Yesterday, March 18th, the new Secretary of Health, Secretary Robert F. Kennedy Jr., issued a renewal of the public health emergency related to addressing the opioid crisis. So now's the time for all of us to think about how patients in recovery from SUD really encounter that system and how we can better support them by creating more seamless and successful holistic care approaches. That also goes for how they access the legal system and how they access maternity care. Also, what can we do to support healthcare providers? How can we educate, empower, and equip those providers with the resources they need to better support pregnant patients who are in recovery from substance and opioid use disorder? And then what can lawyers do to improve the health and well-being of pregnant patients, newborns, and impacted communities? We're going to dive right into the conversation to find out what at least one group of partners in New Hampshire is doing to address all of the above. Let's begin. I'm going to display the next slide with the question, starting off the conversation with Sarah, Metz, and Dustin from New Hampshire Legal Assistance. Let's go to the question slide. Again, thanks for joining us. As Executive Director of New Hampshire Legal Assistance, can you first just tell us about NHLA or New Hampshire Legal Assistance?
Sure thing. So hi, everybody. It's great to be with all of you. And thank you so much to Bethany and the team at the National Center for Medical Legal Partnership for inviting us out of our little corner of the world to talk with colleagues across the country about this project, which we're just so proud of and so enthusiastic about. New Hampshire Legal Assistance is a nonprofit law firm. We are in our 54th year of operation, and we focus on civil legal aid that impacts our clients' basic needs. All of our clients are people with low income. We help people up to an income limit of about 200% of poverty, which is around $50,000 for a family of four, but the majority of our clients actually have incomes under 100% of poverty, so under $25,000 per year for a family of four. The majority of our cases fall into the areas of housing, so evictions, housing discrimination, foreclosures, property tax deeding, domestic violence and family law, including both protective orders and family law cases like divorce and child support and parenting rights and responsibilities, and then access to public benefits, ranging from federal benefits like Social Security, Disability Insurance, and SSI, state benefits, such as the Supplemental Nutrition Assistance Program and TANF, which are administered at the state level, as well as municipally administered what we call local welfare benefits here in New Hampshire. For all of the legal services folks on the call, we are not the LSC grantee for New Hampshire, which means that we are able to use the comprehensive array of legal services tools ranging from legal information to customized advice, litigation in all of New Hampshire state and federal courts, as well as litigation that's aimed at achieving systemic impact. So we do some class action work, we do some Supreme Court appeals, we do some policy advocacy. Our statewide program, New Hampshire's pretty small geographically. We have 5 offices around the state, including 3 in the more populous southern part of the state, and 2 offices in the more rural western and northern parts of the state. We have a great staff. We use paralegals to great impact at our program, which is something that we're really proud of, and that I think is probably the basics.
Thanks, Sarah. Let's go to the next question. After 54 years, with so much reach and flexibility to really leverage the power of the law for both individual and systemic outcomes, can you help the audience better understand, specifically for the civil legal needs services that you provide, how does that fit into the social determinants of health framework that we talk about at NCMLP or through the MLP work that you do on the ground? Help us understand how the civil legal needs services fit into social determinants of health. And we'll bring up a slide on the screen as you talk about that.
Sure. So among the kinds of cases that civil legal aid programs typically handle, and certainly the ones that we do, there does tend to be this focus on helping people to meet their most basic human needs. So their needs to shelter, to food, to medicine and medical care, to physical safety, so safety from domestic violence, for example. And it's really hard to put your finger on a civil legal issue that a legal aid organization can help with that doesn't interact in some way with people's ability to get healthy and stay healthy. So the example that we have on the screen, I think, is a great one. So a social determinant of health might be a food desert, a place where there is long distance to be able to buy fresh foods. Certainly in a state like New Hampshire, we have really limited public transportation. So if people are far from a grocery store, it can be very hard for them to get access to both healthy food and to get access to affordable food, period. Then you can see the spectrum of the social needs. So for example, if a family today doesn't have the fruits and vegetables that they'd like to be able to feed their children, that may be at its root a legal need because the family has experienced the termination of their SNAP benefits or denied altogether. And I think one of the biggest pieces of work that we have to do as civil legal services providers is to help more people understand the array of issues that are fundamentally legal issues that have legal solutions. And there's some great sociological research that I'm sure many of you are familiar with that shows that people actually can understand quickly. I got a paper that says I have to go to court. That's a legal issue. It is far less intuitive for people that my SNAP benefits got cut, and that's a legal issue. So that's I think a big part of our work. Does that answer your question, Bethany?
It does. It does. But speaking of the timeline, so I was thinking about the fact that you're celebrating 54 years of doing this work. Why medical legal partnerships? So the next question really is, help us understand, first of all, how you would define this approach or intervention that we call medical legal partnership.
Sure. So we have actually been operating medical legal partnerships at NHLA for more than 20 years. So this is a model that we feel really committed to. The particular partnership that we're going to talk about today is a little bit newer than that. But at its root, the medical legal partnership is a way for healthcare providers and legal services providers, which could be a range of different kinds of organizations, can collaborate to help the communities that they're working with solve the factors that are impacting their individual health and impacting health disparities within the community. So it's a way of bringing on board in the healthcare setting, solving of problems that can be solved by lawyers and paralegals and other legal services staff, and can't readily be solved by healthcare providers.
Next question for you, Sarah. What led to the decision to implement an MLP focused specifically on maternal or perinatal health?
So great question. So Dartmouth Health, which is the umbrella organization for this partnership, is one of the, if not the premier healthcare providers in both New Hampshire and the eastern part of Vermont. We had long wanted to find a way to partner on a medical legal partnership. I think it was probably a funding opportunity that was the but-for cause of this partnership. But as soon as we started talking about launching the partnership from Moms in Recovery, it just made so much sense because this is an organization that is already really, really trusted in the community, has deeply caring relationships with the folks that they are serving, and also already has a model of bringing social services and other kinds of wraparound services into their healthcare model. So we could really just plug in this legal aspect in a way that would not feel strange, I think, to patients, and would feel like part of the service array. So it just seemed like such a perfect fit. And we found as we began scoping the project that a lot of the civil legal issues that the staff at Moms in Recovery were identifying in the patients that they were working with were the bread and butter of the civil legal work that we do. So there was a really good match there, which in working on medical legal partnerships over the last couple of decades, we have learned is really crucial to the success of the partnership, to make sure that what each partner can bring is what the other needs.
Helping everyone practice at the top of their licenses, as we often like to say, going into the healthcare setting so you can put or move legal aid or civil legal services upstream. Let's go to the next question. Because I think folks might be curious to know a little bit more about the various components of the partnership, Sarah. And so we'll bring up a slide on the screen that we use when we typically describe the traditional core components of the MLP. Can you walk through these 8 and just let the audience know which of these you have in place for the medical legal partnership with Dartmouth?
We do. So we have, I think, all of these in place. So lawyer in residence, my colleague Jonathan is in person every week at both Moms in Recovery and our second site, which is a family resource center called TLC Family Resource Center. We have a variety of different formal agreements governing everything from the funding of the partnership to how referrals are effectuated. We do have a very carefully scoped target population, both in terms of who can be served by the project and what kinds of issues that they can be served with. The legal needs screening is definitely happening. Terry or Jonathan would be better equipped than I am to tell you about the nuts and bolts of that. We have been really fortunate to have dedicated funding. There's both some private philanthropic funding, and Dartmouth Health also directly contributes to the partnership, which was also to us as a partner at the beginning of this project was incredibly meaningful to know that Dartmouth wanted to support this project financially. We have careful mechanisms set up in the form of various releases and retainers to allow for appropriate information sharing while making sure that we're complying with HIPAA and complying with our legal ethics rules. We do a variety of different trainings. We're looking in the next phase of the project to expand to doing more community education through the project. And I think Jonathan would probably say that he is also equally being trained by Moms in Recovery and learning about the way in which they do their work. And of course, we do have dedicated legal staffing. This is Jonathan works exclusively on this project. And I think that's really been critical to its success, is his ability to focus so deeply on this partnership. I'm glad we are checking all of these boxes. Until I saw this slide when we were prepping, I don't know if I would have been able to tell you the list, but I'm glad we can check them all off.
I'm also glad when folks are just in the journey along the way and may identify an area that can actually be that is currently unchecked and can be checked, right? So everyone's on their journey together. I'm glad with Sarah. So I want to take a moment to pivot and hear from the healthcare partner, Terry, and thank you, Sarah. So Terry, I've got some questions for you, but first let's start with helping the audience just understand what is Dartmouth Health, especially the Moms in Recovery program in particular.
Sure. Thank you so much for inviting us here today. This is really lovely. And I just also want to thank you for beginning this webinar with the video that you chose. It really resonated with me and spoke to me. These are our patients, and these are the people that we're taking care of. So our Moms in Recovery program is located at Dartmouth Health in Lebanon, New Hampshire. We are part of the Dartmouth Health Care System, which is our academic medical center. We are located in Lebanon, New Hampshire. We take care of both patients from Vermont and New Hampshire. Our Moms in Recovery program started in 2013 as a response to the opioid crisis. We realized that we had pregnant women who were coming to addiction treatment, but they weren't going to their prenatal care. So we embedded a nurse practitioner, a social worker. I'm a social worker in this program, and we said, let's do a group for pregnant women. And so we started with 4 women, and we thought we'd take care of them until 6 weeks postpartum, and then they would go on their way. And lo and behold, they didn't go on their way. So we started a postpartum group, and then we started another group, and we kept growing. We have, since 2013, taken care of almost 300 pregnant and parenting women. We currently have about 85 active patients in our program. And I would say about 65% of them are from New Hampshire. The rest are from Vermont. We are, as Sarah said, providing care in a very rural environment, which has its challenges. Our program is, we call it an integrated addiction treatment program. We are located in our Department of Psychiatry at Dartmouth Health. So in this program, we have psychiatrists, we have other social workers and clinicians like myself. We have, so we started with just that one group that I told you about. We've now grown into a program that has about 10 outpatient groups a week, including an intensive outpatient program. We have tried to provide a model of care where our patients receive as much care in one place at one time. So in the years that we've grown, we've been able to add a resource specialist, peer recovery services. We've added primary care. Very importantly to us, we have a dedicated childcare worker on site in a beautiful playroom. So the women bring their children with them when they come to treatment. And we are staffed actually by DH volunteers, and we do have one paid employee. So as we've grown, we added a food shelf, and I think that you have a slide with some of the components of our program.
Yes.
And so it made sense for us when we were approached to have legal services. It just was such a natural fit and part of our growth.
So on the screen for the audience, you'll see a list of some of those services bulleted out: the prenatal care, the immunization, family planning, screening and treatment for sexually transmitted infections and hepatitis, and health planning primary care provider. On the next screen, we'll display, and I have more questions for you, Terry, the categories of types of services, behavioral health services, Medicaid services, and supportive services. I really appreciated, Terry, you mentioning that, amongst services, you're thinking about what support someone will actually need to appear at and get through a visit, right? So childcare is provided on site. It's a big deal, right? You don't want someone to think that that is a barrier, that the need for childcare is a reason why they shouldn't be able to show up for an appointment and receive the services from your team. On this list, in the supportive services column, the medical legal partnership is mentioned. So my next question for you is to help us talk about the impetus for actually going into a partnership rather than just referring people to the legal aid partner in town. Like, what was the actual impetus from your perspective as the healthcare provider running the Moms in Recovery program for actually developing a medical legal partnership with New Hampshire Legal Assistance?
Great question. So something that we noticed very early on, we try to refer our patients to appropriate community services. We have some wonderful community partners with whom we work, and I'll use the example of our resource specialists. So our patients often would have access to case management services in their community, but they weren't face-to-face and they weren't relationship-based. And so because we have had long-term relationships with many of our patients and they're coming to us for their medical care and for their addiction treatment, there was a layer of trust that was sort of built in with our treatment providers. So Jonathan and I were talking about this yesterday. I was saying, because our patient has come in and identified these civil legal challenges that they have, amongst other things. So we're doing an evaluation when they come through. And one of our questions is to a patient. I saw a patient this morning, and one of the questions I always ask is, what are some legal challenges that you've had in the past and what do you have going on currently? And you're so right, Sarah, they don't always identify what those challenges are. They're not aware of these other, for example, around benefits. They'll tell me about their prison time and that kind of thing. So because they have a relationship with us, when we bring community partners in here, they very often have pretty quickly build trust with our community partners who are embedded on site with us. So I can bring someone into Jonathan, and what I will say, when he started with us, they were, "What? There's a man here. There's a guy here, really?" And so because it's different, we are all a group of happen to be women providers in this clinic, and they very, very quickly trusted him because they had relationships with us. Does that make sense?
It does. MLP makes the lawyer who's embedded at the healthcare site feel like a part of the healthcare team. It's a healthcare delivery model. Healthcare providers already built up trust with their patients. Usually someone knows when something is medically wrong, but not necessarily when they have a legal problem. So it's super helpful, right? When you have that trusted relationship that you can use to build bridges with your partners in town using, for example, the MLP, and folks may say, as you aptly pointed out, Jonathan, a man, but they've built the trust, and they trust that you're doing it. Warm handoff to Jonathan to continue being supportive in their recovery and maternity journey. I have another question for you, Terry. Before we pivot to hearing from Jonathan about the details of the MLP, especially when it reaches the legal intervention that he might provide, can you just give us a basic explanation? You started to give us a sense of some of the screenings, right? But can you spell out a little bit more for the audience so they understand how a patient goes from the Moms in Recovery program working with you or the healthcare team to then getting to work with Jonathan as the MLP attorney? You started out, as I mentioned, giving us a sense of what a screening could look like, but then what event actually triggers a referral?
Right, that's a great question. So as I was saying, we do a substance use disorder evaluation, and one of the questions is to identify the legal pieces, the legal challenges that they may have. So Jonathan attends our team meeting. So he's sitting in our clinical team meeting every Wednesday from 8 to 9 in the morning, and he's listening as we're running our list of patients and discussing their clinical needs, their social needs, or their legal needs. So he's listening. He's also listening in ways that we don't even realize we're speaking. So we may bring something up, something that a patient told us, and we're not always, he's trained us and he's educated us very, very well, but he will sometimes pick up on things. So one of the things that he does is he sits in this meeting. But then I did an evaluation with a patient a couple of days ago, and she immediately identified that she needed some assistance. So that looks like we're having her sign a release. We have a case manager who I connect her with. The case manager will sit with her and do SDOH screening. Sometimes that's when things are identified. And then we'll make an appointment with Jonathan next Wednesday. He's also available during the week. So there's lots of different ways we connect him, but a warm handoff is ideal. We start talking about him. We talk him up. We've got this great guy. We'd like you to meet him on Wednesday. He's going to be here. Let's have you sign this form. They're very excited to have access to a lawyer. And over again, they say to us, you're taking care of all of us. You're taking care of all of the pieces of my life as I'm trying to put things back together.
That's powerful. That's powerful. Terry, I'm going to attempt to do the warm handoff that you do with the patient population to now hand the audience warmly over to Jonathan. Thank you, Terry. Jonathan, let's dive into the details with you to really better understand once that referral was made, what you do. But before you go into that, can you please first tell us about yourself, and then we'll have a slide on the screen as you explain what your role actually looks like within the MLP. We'll bring up that core component slide again and focus on specific components, some of which is already coming. We have a better picture already painted, but we'll bring that up on the screen. So first, Jonathan, thank you again for joining us. Tell us about yourself.
Yeah, of course, and thank you. As Sarah said, my entire role is working on the MLP. So all the cases that I work on are through referrals from Moms in Recovery or as Sarah mentioned, the second partner location. And I am on site. I've had this role for a little bit more than 2 years now. And I am on site at Moms in Recovery every Wednesday. I'm on site at TLC Family Resource Center every Thursday, and the rest of the week I'm working on those cases. I'm available, by phone, by email, to receive new referrals as they come through, that sort of thing. And once I receive a referral, then I am reaching out to schedule a time, to meet the person, the participant, patient or client, whatever the appropriate word is in the context. And so oftentimes, as Terry said, that'll be scheduling, okay, the next Wednesday, I'm going to be at Mom's, can we meet then? Or sometimes that's not going to work. So we can meet a different time, either in person. Sometimes I'm not always meeting everyone in person, just because of scheduling abilities. So sometimes it's by phone, email, texting, and we're fortunate to our phone system at work also allows texting, which for some people is really, some people don't have email at all, and some people, they might have email, but it is definitely not their go-to mode of communication. So the texting helps.
And John,
Yeah.
can you tell me what exactly does the team look like on your side? Are you working by yourself? What does the legal team that you get to work with look like? Do you have paralegals? Do you also have social workers at the legal aid office that you might be able to work with? What is your legal team?
Yeah, no social workers here. The staff over here are lawyers, paralegals, legal assistants. And I work under the supervision of, a very long time experienced lawyer with, well more than a decade of experience at New Hampshire Legal Assistance. And then I reach out to other coworkers throughout New Hampshire Legal Assistance, regardless of which office, the 5 different offices across the state. If I have a question within an area of law, I'm going to reach out to, the director of that legal program, the housing program or the benefits program, for example, or someone else on the team that has a lot of experience in that. I am a little bit unusual at New Hampshire Legal Assistance because I am a bit of a jack of all trades. I am dealing with the range of legal issues, just about the full range that New Hampshire Legal Assistance handles. I don't handle immigration law issues. If that were to come up, I'd be then trying to do my own warm handoff to that team. But otherwise, most of the attorneys and paralegals here are on, one or maybe 2 of the specialty teams, and I'm unusual in that I'm working across all of the specializations, which means I'm sort of always, I'm jack of trades but master of none. So I'm always getting advice from across the whole organization. But just another straight answer to narrow the answer. Yeah. I am the one staff person from New Hampshire Legal Assistance who is dedicated to the MLP.
Super helpful, super helpful. It's also, it was very helpful to hear that if you do not work on a particular issue, that you also manage that sort of building of a bridge to help that person get a service that you may not provide, but someone else does, whether it's at the law office or elsewhere within the legal community. Going to move to a different question next for you, Jonathan, so that we can dive even deeper and better understand what it's like to be a patient turned client who's traveling through the medical legal partnership. So I want to just pause on this slide for a second so folks know that that graphic that appears here accompanying the question for Jonathan, asking Jonathan to help us understand how the day-to-day operation of the MLP work. You'll see a graphic on the screen that says the patient's MLP legal journey. That was created. It's a new training and job aid that folks can access, and it will be hyperlinked in the chat. Ray has also already plugged that in the chat. Feel free, go ahead and download it. It is a tool that you can utilize to actually help others within your organization better understand what Jonathan is going to explain. What happens after Terry and her team at Dartmouth Moms in Recovery Program provide that referral? What does the legal team do? Do they conduct a conflict check? What does that intake process look like? What does the triaging look like? Similar to what Jonathan just alluded to about doing additional warm hands-offs if need be. Do they do the deep dive intake? What does that look like? And then what does the actual legal care? What does the civil legal service, whether it's advice or counsel or full representation of a client, actually look like? And then what does the resolution process look like? So Jonathan, we're going to pull up a slide prepared for you that allows you to convey to the audience what does the day-to-day operations look like from referral to intake and case handling, and then additional coordination, the closing of the loop at the end. Walk us through that process.
Yeah. Well, as your last slide pointed out, as soon as I get a referral, one of the first things I will need to do, most of the time at least, is the conflict check. And that is to ensure that there's no conflict of interest that would prohibit me from being able to provide assistance to the person who was referred. That might happen, maybe the most frequent situation might be if someone is seeking legal help with a family law matter. It may be that New Hampshire legal assistance is already or previously provided help to the other parent, or the other person on the other side of the case, and then we would not be allowed to provide help to the second person who's asking. That doesn't happen terribly often, but it's we always have to be careful for that. So I'll get the referral, and sometimes it is in the form of I'm given the referral form that the participant has filled out. It's got their contact information, and really not much more than that. I may get a brief summary from Terry or whoever it is passing along the referral, the basic outline of what kind of issue that is. Sometimes it's in person. It is the warmest of handoffs. Terry is walking the person it's a Wednesday. I'm in a room at Moms in Recovery, and Terry is walking this person right over to me and saying, Jonathan, I'd like you to talk with, this person. And so however I'm first meeting with them, I'm going to find out what is the situation. I'm going to interview them, learn about the legal matter that they are dealing with, and whether or not it's the only one. Do they have other issues going on as well that I might be able to help with? And then I'm figuring out what it is that I can do for them. Sometimes the legal issue may be beyond the scope of what New Hampshire legal assistance can deal with. So for example, if someone, one or two times someone has ended up coming and it turns out that what they're really asking for is help with a criminal law matter, a criminal case. And that's just, beyond our bailiwick. So I will then point them to the public defender's office, and to try and help make sure that they get in touch that way. Even in civil law, there are some things that I might not be able to help with. If someone has a personal injury situation where they might want to sue over that, we don't do that kind of case. And I can make a legal referral. I can point them towards possible resources for other lawyers who might be able to help. For those that I can directly help, sometimes it is just explaining, maybe they got a court order or some kind of government document and they just don't understand it. It might be as small as that, and I'm in a position to help them understand it. There might be next steps for them to do that they are going to do on their own, but I can give them advice on what their options are, what are sort of likely consequences of this choice versus that choice, to help guide them on deciding how to go ahead. In the end, that's going to be their choice. And then I may be going forward with representing them in a legal matter. And as the bullet points show here, there are limited representations, there are full representations. Limited would be, for example, I might agree, at least as an initial matter, I might be agreeing to try and negotiate with their landlord for a way to just kind of clear up the dispute so that they can stay if they're threatened with eviction, or maybe to negotiate just a move-out agreement that gives them time to find the next home if they're not going to be staying. Something like that. Full representation would be where it goes to the point where I am preparing to represent them in a court case or an administrative law hearing, that kind of thing.
Those are really, really helpful distinctions, Jonathan. So I just want to note for the audience that those bullet points on the screen are familiar phrases, coding, categories, or labels for the civil legal aid community, but not necessarily for the healthcare community. You have an entirely different set of ICD-10 codes, for instance. So if we look at those bullet points on the screen in the middle section, meet the participant, referral, counsel, and advice. Right, that would be similar to an ICD-10 code that someone on the healthcare side is utilizing, right? Jonathan, the distinctions that you just walked through to help define what these mean, you will have, I assume, worked with your healthcare partner to help them understand some of this advance as far as also laid out in the agreement. But after you conducted this intervention, what do you do to share that information about what you did back with your healthcare partner?
Well, it's going to depend in part because the on the referral form that comes to me from moms, there's a place for the participant to either agree or not agree to the sharing of, I think the phrase is basic case information from me back to the mom's staff. And sometimes people don't initial that. And so I'm really not, at that point, I'm not really at liberty, although I am in partnership with moms, I'm handling that case, it's siloed. The information is siloed.
Yeah.
The most rudimentary, I might share the most rudimentary thing, such as, well, I have sometimes, and I hope I'm not breaking rules when I do this. If there's someone I'm working with and they stop responding to my phone calls or email, something like that. Sometimes I will ask, have you heard from this person in a while? So there might be a minimal thing like that. Other people, they do initial it that they have permission. And even then, I'm still, it tends to be limited amount of information. I'm still subject to the rules of professional conduct, which limit what a lawyer can share about a client. So, but if I am at liberty to share some information, then I can explain, I'm in negotiation at those morning meetings that case reviews that Terry talked about. It might make sense for me to give an update of, I'm negotiating with the landlord. It looks hopeful. We might be able to save this housing.
Yeah.
Something like that, or all is lost. I had the hearing yesterday. It didn't go well. Be prepared for this person to come today and, not be in a very good way.
Mm-hmm. Thanks, Jonathan. We know that folks around the country are exploring the various ways to ensure that information is shared appropriately. Sarah mentioned at the top when walking through the core components that information sharing does consider the ethics for the legal side of the equation, as well as the patient health information. Jonathan, let's go to the next and final question for you and get out of the weeds of process. What are you really seeing in terms of outcomes? Walk us through, if you will, very briefly, what a patient can receive or what can they expect, right, as some of the outcomes of the MLP services that you provide?
Yeah, so in this MLP, the bullet points show much of the range of things that we've been able to help people with. Winning protective orders, domestic violence or stalking protective orders for people, for people who are participants at Moms in Recovery, and which obviously, it can be quite good for their health. And we've been able to avoid evictions, as I was hinting at before, both by outcomes where the person just gets to continue living there indefinitely, and in cases where the eviction may not be entirely avoided, it might be delayed, through a move-out agreement. It might be a move-out agreement that avoids an eviction judgment, so their housing record looks better for any future application they might make, including agreements sometimes with landlords that if the landlord gets called for a reference, the landlord will only limit their answer to confirming the duration that the person was a tenant, that kind of thing. So they're not going to make negative remarks. There's a client that I've worked with from moms who there had been a mistake, but it lives in subsidized housing, and there'd been a mistake by the property manager in calculating her housing subsidy, and that had added up to about $3,000 worth of rent overpayments. And this is, for a mom who had extremely low income. And I was able to show the property manager how they'd made that error, and that mom got a $3,000 rebate. And then Terry, later informed me that that participant was putting it towards getting a car, which would be very helpful to her because her only source of transportation otherwise is reliance on her sometimes abusive boyfriend. So that had, double value in that case. And as the bullet points show, there have been participants that we've successfully gotten them increases in their SNAP benefits, or renewed them if they've been cut down. Cases where there might have been a past overpayment and SNAP and they're losing benefits because of the past overpayment, and we may be able to get a waiver on that, or show that in fact the past overpayment wasn't erroneous, it wasn't an overpayment, so that they shouldn't be losing current benefits to repay so-called overpaid past benefits.
Mm-hmm. Jonathan, I'm just going to interrupt you only because of time and apologize, and just point out that the other examples on the screen clearly indicate the sorts of outcomes that you can achieve utilizing MLP to help stabilize circumstances for individuals who are not only going through pregnancy, which is hard enough, but also recovery, which is a lifetime deal, right? So in addition to the legal services outcomes that Jonathan was detailing, and thank you so much, Jonathan, for walking through those, you'll also see that clearly for medical services, they result in access to legal clients who may be hesitant to otherwise access legal aid. I want to pause and take some questions from the audience. A couple of questions came in, and I want to pose one that came in early and just ask Sarah if she can help repeat what was stated a little bit earlier so that everyone can benefit from what you said, Sarah, about the funding. So one of the questions that came in pretty early on asked if we could address how MLPs are funding their maternal health work, and if you're willing to share, are you facing any sort of instability or such as funding cuts?
So I'm happy to say that this particular project is experiencing, I would say, less funding uncertainty than is typical right now across all of our funding. Generally, I would say this is the moment of the most significant uncertainty, certainly that I have experienced in the last 20 or so years. This project is funded by a combination of private philanthropy, so some local foundations, and then funding through Dartmouth Health, which I believe, Terry can correct me if I'm wrong, I think is part of their population health budget. So, you know, the part of their money that is focused on these kinds of community health initiatives. And again, as I said before, that's been really, really important, I think, to the ability of the project to remain stable and indeed to expand over time.
Especially now, there's so much uncertainty regarding funding. Really appreciate the individual who asked that question and your willingness to respond there. Thanks for pointing out as well that, you know, there are population health services on the healthcare side that might be utilized in addition to philanthropic sources of funding to support this type of work. I know in a couple of other states, they are able to tap into state funding that is specific to maternal health. So folks may want to explore state level funding that might be available to devote to this work. Thank you, Sarah. Terry, I want to let you have the last word. Jonathan helped tee this up in terms of helping us understand some of the benefits. In your words, Terry, can you help the audience, especially the healthcare folks, have a takeaway that they can use to begin to at least explore partnering with the Jonathans and the Sarahs and their teams, and maybe even private attorneys who want to get involved, or their legal aid attorneys who want to get involved. What do you see as the benefits of the medical legal partnership?
Sure. Thanks, Bethany. All of our patients come to us with co-occurring diagnoses. That means they have often PTSD, they have other mental health diagnoses, and all of the patients have been exposed to incredible amounts of trauma, both as children and as adults with their addiction. And have lived and experienced incredible marginalization. They've lost their voice, and they've had lots of experiences with people in positions of power and authority, including our very complex systems of asking for benefits. So asking for help is really, really hard. And I think that having the MLP has been incredibly powerful because it's helped our patients recognize what their rights are, and it's helped them to find their voice.
That's powerful. It's one of my favorite things to talk about as a benefit of MLP. It's empowering to providers, to patients, to systems once they really get going and start to reap the benefits. I want to sincerely thank the audience for joining us today, as well as our speakers for, again, taking time out of their day-to-day schedules. It's very busy right now, very busy in running organizations, as well as providing the direct services to the patients and clients. So I want to thank Sarah Matson-Dustin from New Hampshire Legal Assistance, Jonathan Teller-Ellsberg, also from New Hampshire Legal Assistance, and Terry LaRocque from the Dartmouth Health Moms in Recovery Program for joining us today. Please take a moment, everyone in the audience, to complete the survey to let us know how today's session went and what additional resources we can provide. I'm just going to quickly ask Aubrey Jones, our consultant, to scroll through the next resources slide so that you know how you can look up more information about the Dartmouth program. Let's go to the next slide. So this is the Dartmouth Moms in Recovery or MORE program website. Next slide. On this slide, you'll see additional resources, including the public health emergency renewal, the declaration from just yesterday, March 18, 2025, as well as some still pertinent and helpful information about how MLP can support individuals in recovery from opioid use disorder, as well as how you can broaden out to integrated behavioral health services to even coordinate with court systems and community health centers, additional settings that provide these similar partnership and integrated services. We also have recordings from learning collaboratives that we've run in the past on maternal health, and this was our way to really hone in this year on a unique program that is dedicated to maternal health for moms in recovery. On the next slide, we invite everyone to join us on some upcoming events. Next week, we have a webinar on special population, older adults and families. We then continue our information sharing and privacy essentials group coaching sessions. We're going to get increasingly engaging and deep dive conversations on those sessions. And then we're kicking off a brand new learning collaborative. So sign up now for that learning collaborative. Some very familiar faces and names from the MLP world will be there to help guide people through the building of effective relationships and pitches to get the funding that you need. That's, we know, very, very important for everyone right now. Scan a QR code or use the link to get to the Learning Opportunities page. And finally, that's it. We are closing out. On the very last slide, you can see how to contact us. And Ray has also plugged the link in the chat. I would strongly encourage everyone to sign up for our MLP newsletter, because in addition to Learning Opportunities, that's where we'll share information such as that public health emergency declaration, that renewal of so that we can better address the crisis that is opioid and substance use disorder. Again, thank you so much to the New Hampshire team for helping us present on MLP and maternal health today. Terry, Sarah, Jonathan, thank you so much. And to the NCMLP team, Reha and Aubrey, we're going to close out. Have a great day, everyone. Bye-bye.